Hello, and welcome to the webinar, Raising Adult Immunization Rates, Using Routine Vaccination to Prepare for COVID-19, developed by the Gerontological Society of America in partnership with the American College of Physicians and American Pharmacists Association. This webinar is supported by GSK Vaccines. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live session. We will be accepting questions through the questions feature accessible on the right-hand side of your screen throughout the webinar. My name is Elizabeth Subcheck, your moderator for today's program. I'm director of the National Adult Vaccination Program at GSA. Our speakers and I would like to welcome you today. Doctors Foster, Peskin, Saad, and I are pleased to be a part of this important program. We recognize that COVID-19 has changed many paradigms in medicine and that specific to vaccines, we hope to have several new COVID-19 vaccines on the market in the coming year. Today, however, we will focus on other routinely recommended vaccines, recognizing that they all help control what we can for this fall and beyond. Having well-functioning immunization processes in an office can also ensure smooth implementation of a COVID vaccine once one becomes available for offices. In our session today, I will ask speakers about aspects of age-related decline in immunity and its impact on older adults. We'll hear about specific vaccine recommendations for adults and learn about strategies to increase immunization rates. We hope that you leave today's session with increased knowledge and encourage you to share what you have learned with colleagues. Without further ado, let's dive right into the first topic for today, age-related decline in immunity and what that means for staying healthy as an older adult. Dr. Saad, can you tell us what age-related decline in immunity is?
Yes, hi everyone. So I want to start by saying that age-related decline in immunity, which we call immunosenescence, it's actually the gradual remodeling or change in the immune function, which is related to the normal or what we call normal aging process. So it's the outcome of multiple age-associated defects that would result in immune dysregulation. There's not really a cutoff age where it starts. You know, everyone is a little bit different. It can be affected by other comorbidities as well. You know, however, most researcher, drug companies, policymakers consider usually age of 60, 65 as a cutoff of sorts. That's, for example, where, you know, some recommendations for certain vaccines come from at certain ages. However, there may be clinically meaningful change can be seen as early as 50. You mentioned COVID, for example, with COVID. The older you are, the sicker you can get, and there's like a continuum seen there of this increase in risk, but definitely becomes very significant after age of 60 or 65. So there's multiple factors. Almost every part of the immune system is affected there. So there's, for example, delayed increase in the inflammatory cytokines in response to an infection. So interleukin-6, TNF-alpha, interleukin-8, those cytokines that are associated with the inflammatory response and with some symptoms of infection like fever, and also contribute to viral clearance. They don't increase as fast, but also they don't go down as fast. So there's a delayed decline in these cytokines also, which would lead to a longer inflammatory state, a longer prothrombotic states, leading to an increase in thromboembolic stroke, myocardial infarction. There's also problem with the T cell response and the coordinating or the balance between T helper 1, T helper 2. There's a decrease in B cell response. And there's also other factors which are not directly related to immunity, but like, for example, impaired mucociliary function, decreased respiratory muscle strength, decreased respiratory lung compliance. All those affect also the response. And the flip side of immunosenescence or aging is inflammaging, or immunosenescence or decrease in immunity is what we call inflammaging, which is a baseline low-grade inflammation, poor thrombotic state. that is associated with a lot of the morbidities or comorbidities seen, with older age.
Thank you for setting the baseline on what immunosenescence is. Can you talk now a little bit about the consequences of immunosenescence?
Yes, of course. So collectively, these changes have, they affect the vaccine response. So they would result in poor vaccine responses in older adults, but they also allow infections to run longer unchecked. A lot of symptoms of infections are related to the cytokines or driven by the cytokines. So, for example, fever. So the older adults will not have a fever, and so the infection will not be detected as quickly. Which would lead to lethal infections appearing initially to be more benign. So underestimating the seriousness of the infection, so leading to a different presentation. And sometimes even the infection is not, the infection itself is not detected, but we can see the outcome. Like for example, influenza vaccine, we don't detect the influenza infection, but we can detect the acute myocardial infarction, and we cannot really relate that to the influenza infections that happened a week ago, for example. So it changes the presentation. So it increases also the risk of infection. So older adults and the seriousness of infection. Older adults, those who are 65 or older, make up 60% of hospitalization related to influenza and 75% of death related to influenza. As we know, they are also more affected by COVID. So more likely to have COVID, more likely to have severe disease and to die. So after age of 65, the rate of hospitalization is 5 to 10 times higher, but the mortality than someone in their 20s. But the mortality is 200 to 500 times more. So a very big increase. The vaccine effectiveness is also thwarted by, or it's also affected by age-related decline in vaccine responsiveness, which is leading us to look for more effective vaccines, for example, with higher dose, or vaccines with adjuvants, or other vaccines that can affect, that can lead to a stronger immune response, but also to a longer immune response. Herpes zoster is another place where, we can, or another infection where we can illustrate the effect of age. So more than 95% of American adults have latent varicella zoster, and about half of all adults who live to age of 85 will have at least one episode of shingles. And shingles lead to a change or affects really quality of life because it leads to chronic pain, chronic complications related to pain. It can lead to disability related to pain, insomnia, other problems. There's also evidence that it can lead to cardiovascular and cerebrovascular complications. And so there's a lot of effects beyond just, or just the infection. So every infection will lead to a change in a long-term effect.
Thank you. It sounds like immunosenescence can have a large impact on older adults' ability to fight infection as well as complications then from that infection. What else do we need to know about the impact of this age-related decline in immunity?
So in addition to affecting the risk of infections and severity of infections, and also response to vaccine, so the age-related decline of immunity also affects the ability of the body to keep some cancer, some types of cancer in check, or some type of malignancies in check, because the immune system plays a big role in detecting these malignant cells early on and to avoid the spread of infection. So that is affected also with age. For example, colon cancer is a big one that is affected, breast, prostate, and the other very, most common cancer. And inflammaging, the flip coin of immunosenescence, is also related to an increase of risk of MI, myocardial infarction, strokes. So it really affects a lot of the comorbidities of morbidities that we can see in adults and older adults. Autoimmune diseases are also increased because of this imbalance in immunity. What can we do for this? So so there's some evidence, or there's strong evidence that physical activity or exercise affects the immune system directly, and that will improve physical activity can lead to an improved protection from infections and from maybe also cancers in some cases. Some evidence for that. And it definitely allows an older person to maintain their reserves. So if you have a better cardiac reserve, better pulmonary reserves because you exercise, that means that an infection will not affect you as much. So this is always encouraged. So what we mean by exercise here is, so any exercise is better than no exercise, but in general, we talk about 150 minutes of brisk walking, for example, or swimming. In terms of nutrition, also keeping a healthy diet, what some people call Mediterranean, or what we perceive or we call Mediterranean diet, which is a diet high in fruits, vegetables, whole grains, beans, nuts, seeds, for example, little red meat. In terms of vitamins and other micronutrients, so there's not really strong evidence for any supplementation beyond the recommended daily value for most vitamins. Maybe the one which are studied most are vitamin D, zinc, and vitamin E. So not vitamin Z because it doesn't exist. So those increase or at least making sure we're not deficient. There's no deficiency in vitamin D because that also affects cognitive function, the metabolism in general. Making sure we're getting the recommended daily allowance of zinc and vitamin E. Those are where research has shown most benefit.
That's really great information. Thank you. And I think a great lead in to our next section, where we'll turn our attention to vaccines, which can help boost immunosenescence. So what the recommendations are, why they are particularly important tools to help adults stay healthy. So with that, I will ask Dr. Peskin, we're in the middle of influenza season. Can you tell us about the CDC recommendations and products available for adults for influenza vaccine?
Sure. So really everyone should be receiving his or her influenza vaccination, and the high-dose quadrivalent vaccine, Fluzone high-dose quadrivalent, while not explicitly recommended for persons with an ACIP designation or CDC, is something to certainly think about, having 4 times the level of immunogenicity in that particular product. And again, the importance of influenza vaccination and the broad population, children and adults, really can't be overstated, certainly in the face of SARS-CoV-2. And I think we're doing a pretty good job of getting that message out. And certainly the data that I've seen most recently on flu in the contiguous 48 states in Alaska and Hawaii is reassuring. And probably part of that is also related to physical distancing and wearing a mask. So flu vaccination cannot be overstated in its importance. And again, a consideration for persons 65 and older to get the high-dose quadrivalent vaccine.
Often pneumococcal vaccine gets administered with flu vaccine. Can you tell us a little about recent changes to pneumococcal vaccine recommendations?
Yeah, so the product, the Prevnar product, or the pneumococcal conjugate PCV13, is now given in younger persons and is now in the context of shared decision making with adults. The pneumococcal polysaccharide 23 is absolutely indicated for adults and at younger ages, depending on risk. So the PPSV 23 continues to be recommended in adults, in older adults, for every older adult, and persons that are asplenic, severe asthmatic, COPD, in younger persons, younger than 65.
Great. Shingles is often seen as one of the great success stories for adult vaccines. Can you tell us about the recommendations and why you think so many adults have been willing to get it?
So a few years ago, I did a webinar for the American College of Physicians after I did a blog post called Shingles is Hell. And I can tell you in very colorful language, which I'll spare you on this in this webinar, but having had trigeminal shingles and neuropathic pain for a couple of years, taking gabapentin, and a few weeks of just awful with my eye swollen shut, I can attest, and I'm a otherwise healthy person with no significant underlying immune problems. So it's really awful. And now for some people, maybe not quite as bad on the back or the leg or something, but certainly mine was very profound. And my intention is to get the 2 doses of the current product, which is 90% effective. The recombinant product, Shingrix, even though I had shingles and obviously chickenpox as a kid. So that's my personal intention to do that as well. So it's a can be a very consequential problem, and certainly in persons who may have some level of immunocompromise can really be profound in terms of the consequences of shingles, and even in persons who have quote unquote relatively normal immunity. Again, my own personal journey, I can loudly attest to the great discomfort, and then a couple of years of scratching my face, and my wife saying, "Why do you keep scratching?" I said, "I'm sorry, I apologize. What can I do?" The zoster recombinant RZV preferred, and it is 2 doses.
Great, thank you. Are there any other vaccines for adults that should be on our radar?
Sure. So Tdap every 10 years. Persons who have although we're doing this much less, international travel, persons with liver disease, hepatitis A. Certainly, there are a lot of healthcare professionals on this webinar. I guess most of us are, right, on this particular webinar. So the requirement to get the hepatitis B schedule, which again was a requirement from the hospital for me, and also men having sex with men, persons using intravenous drugs. So certainly protecting those persons from preventable transmission of hepatitis, where we do have a vaccine for A and B. Younger adults, certainly it's can be a requirement before going to college for the meningococcal ACWY, and then Menectra, and then also Meninge B is another vaccination, generally in younger adults. Again, there's some considerations for using those vaccines in older adults, but certainly in those going into the military, going into college, into those kind of dormitory type settings. And then the last one, Haemophilus influenza B. There's certainly some adults based on lung disease and so forth, smoking, that should get that as well. So actually, while not the panoply and rather dizzying number of vaccines for children, and a moderately complex kind of schedule that the pediatricians and family physicians who see children do a great job. There's a lot to keep up with from the ACIP and the ACP and CDC as it relates to immunization for adults.
Yeah, absolutely. That's quite a bit to take in. Thank you. Despite their importance and being recommended, vaccine rates remain very low. We know quite a bit about the challenges that practices and pharmacies face, but we also know evidence-based strategies to address those challenges. So I'd like to transition to Dr. Foster now to talk a little bit about the national level immunization data. How are we doing with rates, and how can medical offices and pharmacies find out how they stack up against those rates?
Thank you. Thank you very much, by the way, for inviting me to this important discussion. It's very difficult right now to find some real accurate data about rates. We see sound bites that are coming from all over the place. When we try to find out exactly what's going on now, COVID has really changed everything that we can see, the data in particular. A statement's come out, the sound bites, some of them come out saying things such as the vaccination rates for adults that are 65 and older have dropped 83%. I saw that number in one of the NFID reports. They talk about the rates for adults that are 19 to 49 years old decline more than 60%. They're low to begin with, so another 60% off of that. So right now, we just have to accept the fact that the rates are low. On normal times, without this, in fact, you can find some information on rates nationally by using some of the CDC information, cdc.gov/vaccines. For example, for the flu, you can find information such as last year's vaccination coverage, coverage in healthcare workers, coverage in pregnant women. These are all in what's called FluVax View. Again, these are a little bit older information. It's last year's information, so it doesn't really tell us a lot what's going on right now. The CDC, though, has several different systems in place to discover the vaccination rates, and among other behaviors. For example, the behavioral risk factors surveillance system. That's a surveillance system is done by telephone interviews of about 400,000 adults. They do it every year. This last year, they asked questions about flu, tetanus, pneumococcus. They can change what they really ask each year. And then there's also the National Immunization Survey. It's primarily children and teens. They mail questionnaires to, or they call parents and ask their demographics about the kids, and then they actually mail questionnaires to their providers. And in the latest one, there was about 10 questions on 10 different vaccines for the providers to answer. But again, the latest data on that is like 2016, 2017 that's published. So we're still looking at quite a bit older data. Some of the other National Health Interview Survey, for example, ask about hepatitis A, hepatitis B, and HPV. In the last survey, they changed that also every year. But the last one published on that was 2017, 2018. So I'm trying to point out that it's just really difficult to find out what the current state's going on. Other things that we can do, state and local health departments we perhaps could contact, but that would require you really to contact them to see if they know anything about what's going on locally. I really do think we get most of our information from the news. There was a report even just yesterday, the Blue Cross Blue Shield report came out that said children may miss 9 million vaccination doses in 2020. Another soundbite that came out from the news, each year 50,000 adult deaths due to vaccine preventable diseases. Measles cases are up. So these type of things come in from the news that they're out there looking for things, so we can find it some of that way. One other way that you can perhaps find some information is to talk to your manufacturer representatives. Believe it or not, they keep an awful lot of data on what we do and how well we're doing it. Usually it's a regional data, not a specific to an office or a pharmacy, but they do keep records on how we're doing with their vaccines. But really the best thing I think is just to look at ourselves. I will tell you that I was told I was told by another person that they were visiting a doctor's office who it was a multi-practice office, and they actually followed a lot of diabetic patients. So one of the questions they asked the pharmacist that was there is about how many of your diabetic patients have been vaccinated with hepatitis B. And this pharmacist replied by saying, well, we've got almost all of them up. So that they decided that this would be a good time to do a survey give a student project. They had a student there, so they said, how about the student go ahead and do this and find out actually how many of them have received hepatitis B vaccine. And they found out there was only 7% of the office of their patients that actually received that vaccine. So one of the things that we can do is look at ourselves basically to see how we can do it. If we don't have time to do surveys like that or the ability to do it, just say, I know we're not there and I can do better. So looking at ourselves, I think, is really one thing we should be doing at this time.
That's really great advice. So it sounds like, especially in times of COVID, now we know that rates for adult vaccines are generally low. Can you talk a little bit more about why that is outside of COVID, perhaps, and some strategies that are well documented to as evidence-based to address those low rates and help to get them up?
Well, the reason they're low right now, other than COVID being an issue, is I kind of break into a couple of factors. There's, first of all, the patient factors. The patient has to take a look at their risk versus benefit, their perceived risk of disease versus their perceived benefit of vaccination. As an example, we hear comments all the time right now about the COVID vaccine, how some people say, well, I'm not going to get it, and other people say, I can't wait to get it, and it's just based on their perceived risk. Well, I'm not going to get that sick from COVID because I'm young, et cetera. So it's their perceived risk versus the benefit. There's some people with personal opinions. They just basically, I never get a flu shot. It's just I don't need it. I've never gotten the flu, or I get sick every time I get the flu shot. It's just their own personal opinion, and sometimes you can't sway that. A lot of it has to do with fear. Are they afraid of it? We don't know. Some other reasons: lack of knowledge, perhaps, misconceptions about the vaccines or the disease itself. Lack of awareness. Do the people even know if they really need the vaccine? They don't perhaps even know that there's one available for certain things that they do. The other thing is particularly with anti-vaxxers, it's this control that they have to have. They know that they can take care of themselves. You know, it's like you can't tell me what to do. I know what to do. I know better than what you do. In fact, there was a comment at an ACIP meeting a couple years ago where one of the anti-vaxxers got up and said, I know all about vaccines. I've got Google. So it's just a perceived control that they have. The other factors, I think, are partly is based on the providers. We're busy. Providers have to see a lot more patients than they used to have to see in a lot less time, including the documentation. It takes time to talk to the patient. It takes time to look up what do they need. It takes time to find out if the patient's already had a vaccine. When the patient says, well, I got the pneumonia shot, well, what shot did they have? We really don't know. So the kind of issues on what to do about this type of stuff, the first thing I would say is put prevention first. This is something that is everybody in the office or pharmacy, whatever the situation that you're in, is put prevention first. We usually think of it at the end of the interview or at the end of the time, but and it needs to be done with every patient at every encounter. One of the ways that we've talked about in the past has been immunization champions. Select someone in your office or in the pharmacy that you can sit there and say, you're responsible for making sure we do immunizations on people, checking their records, et cetera. The biggest thing that I think that people can do, though, is make a very strong recommendation. And from everyone, not just coming from the providers, everyone in the staff at every point of contact, a strong recommendation. There's a vaccine that we strongly recommend that you get. Another thing is using the registry. Again, that's another time-consuming thing, but it is really important. If we could get the registry up to date and useful in that manner, we could answer a lot of these questions about what the patients need. One other thing too is to institute quality measures. For example, like this office that had the students look up the hepatitis B vaccination rate. Is there some type of way you can evaluate exactly how you're doing? That woke that office up, and they have improved their rates since, according to this person I talked with. Dealing with people who are hesitant to get vaccines is a very difficult thing. You know that you can't argue with them. They know what's right. So I have a phrase that I actually learned from another physician that I thought was really good. It says, well, if you don't want a vaccine, what do you want to do to protect yourself? It was just a simple phrase that is good from that standpoint. So a lot of different things we can do, but it's up to us to work at it.
Yeah, I think what I'm hearing from you is that consistent policies and procedures are helpful. I'd like to stay on the hesitancy piece for just a little bit, because I suspect for those on the call, that's one of the most frustrating components of giving a strong recommendation. And so I'd like to open up the line to our other panelists and talk a little bit more about that. So I'm wondering if this question is for everyone. What would you say to healthcare professionals, such as those on the line today, about giving a strong recommendation to vaccinate? Dr. Peskin, would you like to start us off?
Sure. I actually asked a very close friend who's a longtime family physician in Bergen County and a 60-year-old teacher from one of the schools here in Bergen County came in and was flu vaccine reluctant. And Tom mentioned to me that simply going in and helping him appreciate the value of the vaccine and how it would protect not only him, but his students, assuming that there's some still physical in-person schooling going on, and that's variable across the country, and importantly, his loved ones. So that conversation and Tom's point, which I think is well taken, whether it be a advanced practice nurse, whether it be a PA, whether it be an MD, whether it be a DO, whether it be a PharmD, someone who has ability to establish existing rapport with the patient, and to help her or him appreciate why these vaccines are so vital and valuable, and why you're not only protecting yourself, but protecting others, your loved ones, and members of the community, can be very powerful. Another comment that I would make, and it doesn't really address your question about vaccine hesitancy, reluctance, but just from a broad population health management, to be able to have in your organization, whether it be something as large as the Cleveland Clinic or as small as a solo family practitioner, that there's pre-visit planning and alerts built in that allow the healthcare professional, whether she's a physician or he's a PA, to know that the person should be getting certain adult vaccines.
Great, thank you. Dr. Saad, is there anything you would like to say about hesitancy or a strong recommendation?
Yes, actually, so it is like a difficult part, I guess, of our daily job, but a very important part. And I try to make it more about the person, try to see what's important for them. If I may say, just like a personal story, my mom, for example, she's not quite in the older adult age, on the, let's say, older than 60, she's not yet there, but she works. She's like a receptionist at a free patient clinic, and she doesn't listen, of course, like your mom, you're a doctor, but your mom doesn't listen to you, so she doesn't want to take the flu vaccine. Very hard to convince her to take the flu vaccine. But one thing that has worked with her, especially this year, is, well, if you want to see your grandkids, if you we want to keep my kids safe, my brothers, everyone else safe. That's very important thing to do. So try to make something that is important for them. For example, if they want to see their family, if they want to keep their grandkids safe, if they want to stay out there, stay independent, be able to spend time with their grandkids, not put other people at risk. I would also give us strong and direct recommendations. For example, I wouldn't say, well, how about getting the vaccine today? I know I would be more direct. It is today time to get your vaccine. Just, like when you recommend, for example, blood pressure or diabetes medication, I don't ask them, do you want to get your diabetes under control, or do you want to get your blood pressure under control? No, we say you need to get your blood pressure under control because X, Y, and Z. Same here. You need to get your vaccine because it saves your life. It keeps you safe. It keeps others safe. It keeps you doing what you're doing. It keeps you independent. It keeps you, because a vaccine means you're able to see your family. A vaccine means you're able to stay independent. So make them see, a little bit beyond what they are seeing, because beyond what they're thinking. They're maybe thinking, I'm okay today, I don't want a side effect, but make them see why you're really giving it. If they tell you it's not effective, tell them, well, last year I got it, but I still got sick. Well, yes, but you're here to speak about it. You didn't die because of it. That's well, I get it and I get sick after it. Well, imagine then, this is a side effect of the vaccine. Imagine how the real disease must feel. That's, something I use with them. So yeah, I know it's hard, but most people will come to it, will get it. Very few people are ideologically, against it. Most people are just hesitant or don't know better, and they just need to be encouraged to do it.
You make a number of really excellent points and practical strategies. Dr. Foster, is there anything else that you wanted to add on this topic?
I'd like to just reemphasize that last comment. That was great. It's how you approach the patients. You don't ask them, do you want to get your shot today? That's not a question that you ask. You ask them, you tell them very strongly, this is what I recommend for you. Let's set this up. So I think that's a great thing. There are other techniques people have talked about, motivational interviewing, for example, which got different steps in it, but most of us don't really change how we do things. It's something that we're kind of not going to relearn a new approach to our patients, but there are steps in that approach that we can do, and primarily listening to the patient's concerns and trying to address those concerns and having the information available that they might need to answer the questions.
We had a question come in the chat that I think is related to this, and so would like to bring it up now. And that is, do you have any recommendations on how to start the conversation with patients about COVID-19 vaccine? Anybody want to start us off on that?
So I can start off, Dr. Sadeh. So COVID vaccine may be a little bit more difficult, maybe because of all the politics going around it, or the media attention. There's concern about maybe the vaccine is being hastened because of political pressure. But I think there's a lot of effort going on to make sure that the system of approving the vaccine is very transparent. That it is accessible to doctors and also accessible to let's say the lay public, so they can be more trusting in terms of getting the vaccine. That this vaccine, okay, it was accelerated, but there's no corners that were cut. Everybody, everyone did their due diligence to make sure it's safe. And I think from the other side, people understand the seriousness of COVID. I think more than influenza, for example, because they see it on the news every day. So we can use that quote unquote fear to kind of stimulate or the conversation about, or to enhance the the conversation about COVID vaccination.
Great, thank you. Any other thoughts on how to broach that conversation?
This is Steve Foster. I get asked this question a lot, is like, the first question is, are you going to get it? And I say yes, I'll be the first one in line if I'm allowed to do that. I will be the first one there. But the thing they asked me is about, well, what about the quickness of the studies? And I try to explain to them about the fact that while the studies are going quickly, it's because we have a larger population that we're testing it in a shorter period of time. It's not that we're cutting any quarters, we're decreasing the number of people we would try a vaccine in. And then I kind of go over how effective the vaccines that have said that they'd like to do it, and it's good. I just tell them that I'm going to be the first one in line to get it.
All right, great. And then I think Dr. Peskin is, let's see if we can get him unmuted here. Let's see, Dr. Peskin, it says you are self-muted.
Okay,
there we go. You should be able to talk now. Great.
As Dr. Foster said, I'm going to say the same, that I'm going to get the vaccine, or presumably will be in one of the first tranches as a HCP. And so that's one way that I will sort of walk the walk rather than just simply talking the talk. The other thing that I would say is, notwithstanding Operation Warp Speed, there's still tremendous scientific rigor that is going into the vetting of the Moderna, the Pfizer, the J&J, other vaccines, AstraZeneca. So we'll let folks know that this is, while being done expeditiously, is not being done recklessly, and that the consequences of SARS-CoV-2 are profound, as we see every day in the news and the media, in terms of the number of cases, the number of deaths in the US, the number of deaths internationally. So those would be some of the kinds of things that, you know, we would say, and again, the ability to protect not only oneself, but one's loved ones.
I'd like to stay on COVID for a few moments. What do you think healthcare providers are going to need to do to prepare their offices for COVID vaccine?
Yeah, so I was asking the same high-performing primary care clinician. So they'll, if with the Pfizer vaccine, it'll come in the dry ice. When they open it, they'll have 5 days in the refrigerator, presuming there'll be a drastic shortage of dry ice. So you'll be able to use that vaccine that comes in a shipment for 5 days, refrigerated at regular refrigeration after breaking the seal. And then the Moderna vaccine can stay frozen and then be unfrozen. And so I would say, just from what I'm hearing from independent practices, from health systems in New Jersey, they're certainly thinking about preparing for their end of the supply chain, which is the end of the supply chain. It's the step before actually administering. I don't know if Dr. Foster or others have comments on how a CVS or a Walgreens or a Walmart will be responding.
Yeah, thank you. I think part of the concern that people has is, are they going to have these ultra low temperature refrigerators? And I think really, and by the way, if you really want to know what's going to happen on December 1st, or next Monday, I think it is, the ACIP is going to meet again to talk about what to do. And they've been meeting weekly, monthly, to discuss this. The work group, the CDC work group on COVID vaccine distribution, and all have been meeting weekly. And public can listen into those. So this next session that's coming up is going to be talking a little bit more about the distribution. But I've been telling pharmacies that don't worry too much about this deep freeze situation right now, because the first group is probably going to go to major medical centers and places that can handle it, while they actually try to get the healthcare providers vaccinated. So they're not going to go out to everybody right at the first time. Maybe by the time that they do spread out to the general public, we'll have other vaccines available that are easier for storage and all. And if not, they'll work out the differences by that time.
Great. Dr. Assad, is there anything you'd like to add?
I would add that I know that some pharmacies like CVS and Walgreens, for example, and others are partnering with long-term care to provide vaccinations for providers and for residents especially because of some of the vaccines need for a deep freeze. I'm not sure how they are partnering with clinics, but that may be worth looking at in terms of information. And I also know that in states we are required to, or providers who are interested need to sign up and on a state level to be registered as a COVID vaccine provider. So that's something that providers who are interested in can start looking at, as of now. And I'm sure, they will get a lot of questions. Providers are getting a lot of questions about this. So when they are faced with this question, should I get the COVID vaccine? Now that we don't have it yet, we should say yes, and you should also get the flu vaccine, which we have now. Use it as an occasion to also push the vaccine that we have and that we know work.
Great. Thank you all for those responses. We are going to move into the question and answer portion of our webinar now. But first, on behalf of the Gerontological Society of America and our speakers, I want to thank all of our attendees for their participation today. Thank you again also to GlaxoSmithKline Vaccines for providing support for this program. Just a reminder that we are recording the session and we'll send you an access link by email once it's available. You'll be able to download a copy of the presentation slides from the website listed, and when the recording comes out, you can also access them in the handout section on the right-hand side of your screen. Before we take our first question, please know that a survey will automatically launch after the webinar. In an effort for continual improvement, we would very much like to hear your thoughts, so please provide feedback before clicking the survey link at the end of the webinar. Just a reminder now, as we move into our question and answer session, that you can type and send questions using the questions feature in the dashboard accessible on the right-hand side of your screen. We will not be using the raised hand feature today, so if you have a question, please be sure to use the questions panel. We'll do our best to address as many questions as possible, time permitting. So we do have one in queue that says, let's see, will patients who have had COVID be recommended to get the vaccine?
I think might be able to take, this is Steve Foster. And by the way, the ACIP meeting is going to be November 23rd. I just remembered that it was moved up. So anybody wants to listen to that, it will be there. I asked that specific question of the ACIP work group too, and it sounds like to me that they're not going to try to screen patients for that, because there would be many people that were asymptomatic and not knowing whether they had COVID or not. So it was safer to vaccinate those that want to get vaccinated, again, based on the groups that they have about when. But yes, it sounds to me like they're going to vaccinate even if you've had COVID.
Great, thank you. As others place their questions in, I'd like to ask Dr. Peskin, what do you think are reasonable incentives that help motivate offices and pharmacies to raise their rates?
Yeah, really good question. So there are a raft of different performance-based and value-based out there, and coming from the health plan side, the payer side, I can attest to that. So one of the things that health plans do is to financially reward healthcare professionals, organizations to raise the rates to achieve the desired levels or higher levels, or whether it be around HEDIS or Medicare Star or ACIP recommendations. So that's one thing. And money's not the only thing that matters. So another thing is getting the healthcare professional organizations feedback in terms of how you're doing. So there's oftentimes a cognitive dissonance. Oh, I'm getting 80% of my person's flu vaccine. Well, at least our data shows it's 42%. So there's a gap there. So getting that information, that feedback to the clinicians, again, whether she be an internist or he be a family physician or an advanced practice nurse, at the group level and at the NPI level. So those are things that we do. So there are financial levers that we pull. There's simply providing the feedback and information to the clinician or to the practice or to the group, so that they can. Another thing that we do as a payer is working in harmony with our clinical partners to, again, dispel some of the misperceptions, some of the tabloid medicine that is why certain people say, oh no, vaccines are harmful or they cause autism or other things. So that sort of marketplace of ideas is another place where we operate with our clinical partners.
Great, thank you.
Using social media and direct direct outreach to persons, whether you call her a member, whether you call her a patient, whether you just call her a human being.
Yeah. All right. Dr. Foster, can you talk a little bit about the role of the pharmacist in increasing rates?
Well, fortunately, the pharmacists have been given legal authority now to at least legal protection to give vaccines without some of the restrictions that each state imposes upon pharmacists. So I always like to say that whenever we're in a crisis, pharmacists can do about anything, and then after the crisis is over, it's taken back away from us. But at least the advantage is right now pharmacists have the ability and the legal protection to give vaccines, not only the COVID vaccine, but also the children's vaccines. And I want to reassure most physicians that pharmacists do not want to interfere with a pediatric practice. In fact, we have in the state of Tennessee have had the legal authority to give pediatric vaccines since we first started in 1998. And it's never been an issue because pharmacists are not really interested in interfering with practices, but they're there to help. And so I think that while we're all busy and doing things, when we get in a situation where we need to step in and do it, I think all providers will do that. It's not going to be an issue.
Great, thank you. We had a question come in from someone in our audience asking about whether there are any contraindications to COVID vaccine. Do we know that at this point?
This is Lisa. We don't know yet. We don't know that yet. I mean, the companies or the drug makers are touting that their vaccines are safe. The contraindication that they speak of in studies are the general contraindication that we see in most studies where a new medication or a new vaccine is started. So we really don't know that. We don't have enough information about that yet.
I agree, and the other thing too is that once the FDA approves it, even if it's an emergency use, they will have that information available at the time.
Just going back to Dr. Foster's comment, something I failed to mention, we see immunization and primary care and immunization as part of the constellation of comprehensive person-centered primary care as a team sport. So we're definitely in New Jersey working with the New Jersey Immunization Network, American College of Physicians, American Academy of Family Physicians, advanced practice nurses, pharmacists. Our chief pharmacy officer is deeply involved in raising the rates and working with our various clinical partners to do that. So very much, again, would emphasize to the Gerontological Society of America that your work is very much appreciated and valued, whatever your professional designation may be to work in a team-based way to support adult immunization.
Wonderful, thank you. I don't see any other questions from our audience at this time, and so I'd like to just take a moment to highlight some references that Dr. Sade provided, and then also some resources from GSA, ACP, and APHA that can be helpful to raising immunization rates in adults. You can find those in the handout that's on the right-hand side of your screen in the slides there for more information. So I'd like to just take a moment to close our program out today. Thank you to our panelists. Thank you to our attendees. We greatly appreciate your time and participation. This is the end of the program, and we look forward to raising our immunization rates together across professions in the coming months. Thanks, everyone.
Thank you. Appreciate the opportunity.
Thank you.
All right, bye.
Bye-bye.